I'd like to introduce our presenter for our webinar, Clinic Transformation Through Nursing Practice, How Healthcare Reform Affects You and Your Clinic. Today we have speaking Bobby Wunsch. Bobby is the founder and partner of Pacific Health Consulting Group. She is a healthcare and management consultant who specializes in working with safety net providers throughout California. Bobby has spent the last 40 years working within the public and community health sector in the delivery of women's reproductive health, primary care, and specialty health services. And much of her work has focused on financing and operating expanded health services for low-income, uninsured individuals in a continually changing environment. We're thrilled to have Bobby with us today to talk about healthcare reform and how it affects you and your work environment as a frontline clinician. With that, I will pass it over to you, Bobby.
Thank you, and good afternoon. I'm going to talk and engage in conversation with you about the Affordable Care Act and its implementation as we know it and as we're anticipating it beginning in just a few days on October 1st, 2013. In March of 2010, as you know, President Obama signed into law a 2,000-page law transforming or proposing the transformation of the national healthcare delivery system and ensuring that most Americans would, starting in 2014, have health insurance either provided by the government through the Medicaid program or Medi-Cal in California or through health insurance exchanges in California called Covered California, either free of cost, with subsidy, or for people over the subsidy income, people would be able to purchase insurance if they were uninsured at a lower cost than on the commercial market. The Affordable Care Act has four major strategies. The first is insurance reform. We'll talk about that in just a few minutes. These were requirements, most of which have already gone into play, that affect all insurance companies, whether they provide commercial insurance, whether they are operating within the exchanges, or whether or not they're in the Medicaid program. Coverage expansion, which is the focus of most of our work right now, and that's the effort to expand health insurance coverage to the uninsured. Delivery system redesign, which certainly will affect the nurses in this program and directly affect the Department of Public Health in San Francisco and all of the clinics and San Francisco General Hospital. And this really is where we're talking about transformation of the delivery system, to make it more effective and to make the patient experience more engaging. The fourth, and probably in some people's minds, the most difficult part of the Affordable Care Act, but the one that must happen and has begun, but will not be fully implemented for a number of years, is payment reform and how providers and insurance companies will be paid for the services that they provide to their insured beneficiaries. Simply put, and I think we'll just start at the most simple level, the Affordable Care Act is a three-part formula. So if you don't remember anything else from today, this is what's most important. The Affordable Care Act requires insurance companies or insurers to offer coverage to anyone who wants it. Now, there are some exceptions, which we'll go into in just a few minutes. But for the majority of people who live in the United States, an insurance company can no longer deny coverage because of medical conditions. And this is called, in insurance parlance, guarantee issue. So the first part of the formula is that insurance companies must offer coverage to anyone who wants it. Secondly, everyone, and again, there's a caveat, not everyone, we'll talk about that in a minute, but most Americans will be required to have health insurance, and this is known, as you probably know from the Supreme Court decision, the mandate, the individual mandate, where each individual is required to have insurance. There are several categories of people who are not covered by the individual mandate. The largest group of individuals not covered by the individual mandate are undocumented individuals. Second largest category are legal immigrants who have not been in the United States for more than 5 years. And the third category are members of Native American tribes. They are not governed by the Affordable Care Act because of tribal sovereignty issues. But again, the biggest group of people who are excluded from all parts of the requirement of the individual mandate are undocumented individuals. And the third part of the formula is that the government will help people acquire insurance through either the Medicaid program, which is free to the recipient, or through subsidies from the health insurance exchange. So again, the three-part formula, not to be forgotten: guarantee issue, which requires insurance companies to offer coverage to anyone; 2, the individual mandate, which requires everyone to have health insurance, and if you don't have health insurance, an annual penalty, which exists already in the Medicare program, but will be part of the Affordable Care Act. And the third component is that the Affordable Care Act will help people afford coverage either through the Medicaid program or through subsidies. Excuse me, did someone have a question or a comment? Okay, then we're going to go on. So what's happened so far? I think many people are curious about what's happened so far. Many of you probably know that a number of insurance reforms have already gone into place up to today. The first is that young adults have been able to stay on their parents' health plan up to the age of 26. So many of you know that when young adults turn 21 or when they graduate from college, they are dropped from their parents' health insurance if their parents are covered. This changed the rule, and 4 million young adults remained insured because of this component of the Affordable Care Act. Insurance companies can no longer deny coverage to children with pre-existing conditions, and as of January 1st, they can no longer deny coverage to adults with pre-existing conditions. So many of you know people who had serious illnesses or poor results on a pap smear or sexually transmitted diseases who have been denied coverage because of those pre-existing conditions on their medical records. That no longer can happen. Insurance companies aren't able to place dollar limits on new healthcare products for individuals signing up. And many of you, if you look at your own healthcare coverage, you'll see that you have a dollar limit on your coverage of $1 million or $3 million. The amount that the insurance company will spend on you throughout your lifetime, those limits can no longer be part of your coverage. New health plans, starting January 1, and some of them have already started this, must offer preventative and screening services with no copays to patients. So any of you who drive up Highway 80, you'll see billboards between the maze, right before getting on the Bay Bridge, all the way down to Fremont. You'll see many billboards advertising different insurance companies, no charge for preventative health services. This is brand new. And as part of the Affordable Care Act, Medicare now will cover preventative services and screenings, which they never did before. So these are some of the insurance reforms, that first pillar of the major strategies of the Affordable Care Act, that have already gone into place and are already impacting both access to care, coverage, and changes in the delivery system. Okay, well, let's let's go on now and talk about what's about to happen. So there's been so much talk in the press, so much talk in the media, so much talk, I'm sure, in your own circles, professionally and personally, about the Affordable Care Act, which has come to be known as Obamacare. And originally, Obamacare was a derogatory term used by those opposing the Affordable Care Act. It's now come to be the way people refer to this program, whether you are a supporter or not. The big thing that's happening, that second pillar of the Affordable Care Act coverage expansion, is about to begin. So starting on October 1st, the Medi-Cal program is going to start enrollment of people who have not been eligible previously. The program is going to expand dramatically with benefits beginning January 1. So starting October 1, you can complete an application online, in person, by mail for the Medi-Cal program. And if you're qualified, your benefits will start in January. And Covered California, which is California's health insurance exchange, open enrollment will begin on October 1 with, again, coverage starting January 1. So many of you have probably already started seeing advertisements for Covered California, particularly if you watch the Spanish language media, either the novellas or Spanish language radio and Spanish language television, because 75% of all of the uninsured people in California are Latinos. So there is a very targeted outreach effort going on to Latinos, and there will be advertisements on all the media outlets starting in about 3 to 4 weeks. You might ask, why does the Affordable Care Act focus so much on insurance? And one of the reasons, and the main reason, that the Affordable Care Act focuses so much on insurance is because research has shown over the last 50 years that people that have health insurance, whether it's government-sponsored health insurance like Medi-Cal or Medicare, or private commercial insurance that they buy on their own or that they get through their employer, people who have health insurance, rich or poor, have better health status than people who don't have health insurance. And if the principal focus of the Affordable Care Act is to increase the health status, to improve the health status of all people living in the United States, health insurance was one main vehicle through which this could be achieved over time. So that second pillar, which is coverage expansion, focuses on getting every American, with the exception of those groups that I mentioned earlier, in particular undocumented, who are excluded from this coverage expansion, health insurance. Okay, here we go. So let me explain a little bit about how the coverage expansion is going to work. Currently today, the Medi-Cal program in California has 85 different categories of people who are eligible for Medi-Cal, but many different very low-income people not eligible. So, for instance, as you know, as nurses in the Department of Public Health, homeless people, for the most part, do not qualify for the Medi-Cal program, which is why they're on the Healthy San Francisco program, and previous to the creation of Healthy San Francisco, on the General Assistance Medically Indigent Adult program. The Medi-Cal program is changing and it's expanding, and we'll probably have an additional 3 million people statewide eligible for the Medi-Cal program. The income level for people eligible for the Medi-Cal program will be going up by a third, so that individuals with incomes up to $14,000 a year will be eligible. Families with incomes up to $88,000 a year will be eligible. There will be no asset test. Currently, there is an asset test. If you have a little bit of money in the bank, you're not eligible for Medi-Cal. But the biggest change in the Medi-Cal program is that single adults without dependent children living at home, and adults who are not disabled will be eligible for the Medi-Cal program. So some of you may be familiar with the term single childless adult. It's a Medi-Cal term. It doesn't mean you're single. In other words, it doesn't mean you're not married, and it doesn't mean you don't have children. But it does identify a group of people, such as homeless individuals, who do not have dependent children living at home. They may have children, they may be married, but those people don't currently qualify for Medi-Cal, because in order to qualify for Medi-Cal, you either have to be low income and have dependent children living at home, or be low income and be designated as disabled. So the rules for Medi-Cal are changing dramatically, and the income levels are rising. So more people will be eligible for the Medi-Cal program. Covered California will be eligible to people 133 to 400% of federal poverty, and those individuals will be eligible for subsidies. People who are uninsured and over 400% of the federal poverty level will be able to buy insurance in Covered California, in the exchange, but there will be no subsidies for them. And as I mentioned earlier, undocumented individuals and new legal immigrants are not included either in the Medi-Cal program now or after January 1, and are not eligible to buy insurance in the health exchange. So this shows you, this chart, the income level for people that will be eligible for the Medi-Cal program, people that will be eligible by income and family size, Covered California or the exchange. And the subsidies that will be available for people who are buying insurance in Covered California will be based on a sliding scale. And for the lowest income people who are eligible for the exchange, so those people that are not eligible for Medi-Cal, but are just a few dollars over the Medi-Cal top limit, will actually be able to buy comprehensive health insurance in the exchange for as little as $20 a month, plus certain copays, if we were lucky enough to get everybody insured over the next 3 to 5 years that are eligible. So in the most ideal scenario, we would go from 15% of the total population under 65 uninsured to less than 5% of the total population under 65 in San Francisco County uninsured. This is the potential impact of the Affordable Care Act on people living in San Francisco. Now, it's going to take time for people to get insured. It's going to take time for people to learn about the program. It's going to take time for people to learn how to access health care services for preventative and primary care. But again, this illustrates the potential of the Affordable Care Act in reducing the number of uninsured people and, over time, improving their health status. These are the health plans that are participating in the Medi-Cal program, and the health plans that have been designated to participate in Covered California. All of Medi-Cal in San Francisco, with the exception of emergency Medi-Cal, and all of Covered California will be through health insurance companies that are managed care plans. So as you know, the San Francisco Health Plan is the major managed care plan for the Medi-Cal program. It has about 70% of the Medi-Cal beneficiaries in it already. And Anthem Blue Cross is the commercial plan in San Francisco operating the Medi-Cal program. The Covered California health plans include Kaiser, Anthem Blue Cross, Blue Shield of California, HealthNet, and the Chinese Community Health Plan. So if you go on the Covered California website, and here are the addresses for Covered California, you can see the benefits in each of those 5 health plans. And you can also go to the insurance calculator and put in your income, your cousin's income, your child's income, and it will calculate for you what the cost of your subsidized insurance will be if you're eligible for a subsidy, and it will show you the 4 options for plans. And each plan option has a different level of copay. So the least expensive plan has the highest copay. The most expensive plan has the lowest copay. I would really encourage each of you to go to these 2 web pages to learn more about Covered California, to learn more about the benefits, which are very comprehensive and required by each of the health plans to provide, and then to see how the subsidies work. You'll have a better idea of what your clients are going to be taught and what they're going to be facing as open enrollment begins and as Covered California and Medi-Cal expansion begins. So again, just to review the date, starting October 1st, open enrollment for Covered California will begin. And in this first year of the Affordable Care Act, coverage expansion implementation, that open enrollment period will last through March of 2014. After March, you will not be able to apply for Covered California coverage until the following October. And then in subsequent years, open enrollment for Covered California will be 3 months long. Medi-Cal enrollment is continuous, and you can apply online, in person at county social services offices, or by mail, or over the telephone for Medi-Cal on an ongoing basis. The expanded coverage for those new categories of individuals, applications will be processed starting October 1. Again, for both California, Covered California and the Medi-Cal expanded population, benefits will begin on January 1. So let me just stop again and see, before we go into the next section of the presentation, to see if anyone on the phone has any questions about the coverage expansion component of the Affordable Care Act. Any questions?
Bobby, we do have one question that came in, and that is, what's the definition of preventative care and what's included in that definition?
Right, that's a great question. There is, if you go to the Covered California website, you'll see the full list of preventative services, but they include everything from immunization to pap smears to mammograms to prostate cancer screening for men. So there's a long list that was created originally in the Affordable Care Act, and then family planning services were added on the recommendation of the Institute for Medicine. So family planning services, including contraceptive supplies, are also included in preventative services. So each of the health plans in Covered California are required by law to provide a set of essential benefits, which include preventative services, so that the coverage within the 4 different categories of plans is very similar and very comprehensive. So again, I urge you to go to this web page for Covered California to see not only what the health plans are, to calculate the cost of your benefit, but also to see what the list of services are. And I think you'll be very pleased at how comprehensive both the preventative services are, but all of the essential benefits in general. There's 3 other big topics that I wanted to talk with you about that really form the basis of those 2 other pillars. The delivery system transformation, which affects each of you certainly as you conduct your healthcare practice, and also payment reform. So the big topics that I wanted to talk just for a few minutes about are the AAA, which I hope you're very familiar with, the patient-centered medical home or the patient-centered health home, and pay for performance, otherwise known to us as P4P, pay for performance. Let's just start first with the triple aim. And for most of you, I think you know, I hope you're aware of the concept of the triple aim. The triple aim really is the backbone of the Affordable Care Act. And it really is the concept of identifying and delivering the best care for the whole population at the lowest cost. So again, the purpose and goal of the Affordable Care Act is to improve the health status of the entire population of the United States. And the triple aim has three components. Improved patient experience, that the patient's experience with the healthcare system is expanded, that the focus is not just on one individual's health, but on increasing the health of the whole population through looking at data and using data to measure improvements in health status. And the third and an equally important component of the AAA is lowering the cost of care. And as you know, this is a huge issue as healthcare costs have been rising in the United States to the highest per capita cost for healthcare services of any industrialized country in the world. When we talk about the AAA, you can think of it in these three terms: patient experience, population health, or lower cost, or we use a short version: better, cheaper, faster care. Better, meaning population health. Faster, the patient experience. Patients are looking for satisfaction and a better experience when they use healthcare services. And cheaper being the lower cost. So the AAA is really the backbone of the Affordable Care Act. Patient-centered medical home or the patient-centered health home, I also hope you have not only heard about, but that you are implementing in the clinics that you work in. And this is an expansion of the concept of the primary care provider. So many of you will remember that 15 or 20 years ago, nothing new to people working in the public sector and public health, but the managed care plan really began a push to encourage that every participant in an insurance program, particularly in managed care, and this is certainly true in the Medi-Cal managed care program, would have an identified primary care provider, and that for the most part, that would be the provider that they would see. And over the course of a number of years, many of you, I'm sure, have participated in programs to encourage people to choose a primary care provider, to see their primary care provider on a regular basis, and in recent years, to impanel to providers a certain set of patients for whom that provider would be the primary care provider. The concept of the primary care provider has now been enlarged in the concept of medical home or the health home to encompass the concept of team-based care. So it's not just the physician or the physician's assistant or the nurse practitioner that's key to the patient's care, but it's the team of people that are assigned to deliver care, including a nurse, including a case manager, including the medical assistant or medical assistant, including the care coordinator. That the team has now a panel of patients that they're responsible for seeing, and that when the patient reaches out to the clinic or to the healthcare facility, they might talk to the physician or the nurse practitioner, but they might also talk to the nurse or the care coordinator or the mental health provider, depending on their needs that day. And in this way, patients can enhance their experience by getting directly to the person who can help them with that. Easy access to the care teams and whatever member of the care team is another major component of the patient-centered medical or health home. Integrated behavioral health services, both mental health and substance abuse services, are a very important part of the patient-centered health home, along with the implementation of electronic health records or electronic medical records, EMRs, and EHRs. And I think many of you know that the adoption of EMRs in the safety net, in the public safety net, and in the community health centers has happened at a much faster speed than anyone ever intended, in part because of the funding in the Affordable Care Act called Meaningful Use that providers have been given as incentive to adopt electronic health records. Patient engagement and care coordination are also essential components of the patient-centered medical home and the patient-centered health. The third component that I wanted to mention is what we call pay for performance, or P4P. And I think if you look ahead over the next 5 to 10 years, more and more of healthcare services will be paid for based on outcome measures, so that providers are paid for the outcomes of their care, in part, not just for how many patients they can see in a day. We already have a number of pay-for-performance programs or strategies in California through the Medi-Cal program, and the Department of Public Health and all the other safety net providers in San Francisco who work with the San Francisco Health Plan or with Blue Cross are already paid for a certain small portion of their care based on outcome measures. The health plans look at the outcome measures for certain specific conditions, like what percentage of diabetics are getting eye exams and foot exams, what percentage of eligible patients are getting mammograms at the regular time, what percent of adolescents are getting a well care, and based on the measures that the health plans and the state agree on in the Medi-Cal program, providers are getting incentivized payment for meeting certain outcome measures. This component of the Affordable Care Act is only going to be expanded over time. And key to the success of changes in the payment system will be accurate data systems using the electronic health record where outcomes can be measured, monitored, and improved over time. Likely, those clinics, both the community health centers and organizations like the Department of Public Health, who are designated as federally qualified health centers and get enhanced payment rates in the Medi-Cal system, likely the enhanced payment system will change from the way it is organized today through a pay-for-performance system. Let me just stop and see if anyone has any questions about these three components of the delivery system: the AAA, the patient-centered health home, or pay-for-performance. Okay, well, let me just wrap up by saying that we're going to see many changes over the next, I tend to say, over the next 20 years. People say, Bobby, you're not optimistic enough. These changes are going to happen over the next 5 to 10 years. I think if we could zoom ahead 20 years and look back, we'll see in 20 years a very different healthcare delivery system than we have today. And it's going to change year by year, day by day over the coming years. And in 5 years, we'll mark significant changes, and in 10 years, we'll mark significant changes. But I think in 20 years, it will be radically different than it is today. We'll have more insured patients. We'll have payment incentives based on demonstrated outcomes, and data will be gold. It will drive all healthcare decisions and payment methodologies. The patient-centered medical home or health home will be the core of how care is delivered, particularly for people with complex chronic conditions. There'll be new partnerships with different kinds of providers who today may be competitors, today may be simple referral agencies, but who will need to integrate care and organize care in new ways to make the most out of both the payment methodology and care coordination to improve access to care. And to imagine a county like San Francisco where the uninsured population will be potentially half of what it is today, or even two-thirds of what it is today, a much smaller group of people for whom access to care will be difficult to achieve. So as we look ahead, you may want to look at any of these websites to keep yourself informed about what's changing. All of these web addresses have daily bulletins of changes in the healthcare reform or the Affordable Care Act. Any one of them will keep you up to date on the policies and changes that are happening at a state and a federal level. And if you're particularly interested in the public health changes that are ahead and changing, Trust for America's Health focuses very specifically on the public health aspects of the Affordable Care Act. Okay, so I'm going to go back to one slide that I just want to repeat so that you don't forget this, and then we'll check once more to see if there's any further questions before we move. Again, the Affordable Care Act the bill was 2,000 pages. There are thousands of new regulations that the government is creating to manage the program. But the key essential ingredients, again, the three-part formula. Insurance companies must offer coverage to anyone who wants it, regardless of their past health history. The Affordable Care Act requires everyone, with those few exceptions that I mentioned, who are not covered by the Affordable Care Act, to have health insurance, and there are penalties if you don't purchase health insurance. And the government will be providing subsidies either through the Medi-Cal program or through Covered California to help people afford health insurance. So again, guarantee issue, individual mandate, and government subsidies to make sure that people access health insurance and over time increase their health status and the health status of the entire country. Well, I hope this information has been helpful to you. Again, I urge you to keep your eyes and ears open over the next few weeks and certainly over the next 3 to 6 months as every healthcare provider in the safety net works very hard to begin the process of converting their uninsured patients into patients who have health insurance coverage. So thank you all for your attention. And Laura, I'll turn this back to you.
Great. Thank you so much, Bobby. And if anybody has any questions that come up over the next few days, then feel free to send them in to me. And that's Laura at myicln.org. Thank you, everybody, for joining us today, and we will be in touch with everyone soon. Thank you again, Bobby.